Again, another less defined topic, which is less defined, and also the management is not that well defined again. And our next speaker is Dr. Gourav Sannyasi. He is talking on FMS, CFS, PMR rehabilitation.
So, thank you, Dr. Devanjan, for an excellent talk. Good afternoon, everyone. I'll just start the presentation of management of chronic pain syndrome. So, we know the three types of pain naturally we see. One is nociceptive pain. If there is any trauma, or there is any skin breach, the pain that is helpful, that is nociceptive. Any kind of nerve damage leads to neuropathic pain. And the third point is the nociplastic pain or the chronic pain. So there is no ongoing tissue damage, but there is a sensitization of the spinal cord, mainly the central nervous system, that leads to nociplastic pain. I'll just discuss one case. On patient, 38-year-old female, is a corporate accountant. She is complaining of widespread musculoskeletal pain for last 2.5 years, associated with chronic fatigue and poor sleep quality. At the same time, she is complaining of poor concentration at work. She has mood disturbances and reduced work performance. If you delve more into detail, you can see that the onset is gradual, and that is following the work-related stress. Initially started with the neck and the shoulder region, and now it is progressed to the whole body. The pain characteristics are dull aching, is exacerbated after prolonged sitting and stress. There is a minimal relief with and patient despite taking multiple consultations, and all the diagnostic test results came normal. Associated symptoms like sleep. Now we take the personal history. You see that some occupational factor, that there is a high stress at work. The job is almost 10 to 12 hours, a desk job. There is a poor ergonomic workstations. There is a family stress, some interpersonal conflicts, progressive social withdrawal. There is no time to work. There is some behavioral patterns like because of the pain, patients is mostly has become sedentary lifestyle. There is fear of movement. He is avoiding going to the social gatherings. So these are the behavioral symptoms. Now we'll do a history analysis. So this is the patient is suffering from chronic pain. So this is not a symptom. This is itself a disease. So when there is a primary pain, because no other diagnosis, then we can call it as fibromyalgia or chronic widespread pain. And when there is underlying conditions like osteoarthritis or rheumatoid arthritis, then you can call it secondary chronic pain. So this has already been discussed by the previous speaker. So chronic pain is a biopsychosocial framework. So it's not only biological factors. The nervous system is sensitized. There is genetic predisposition to that. Along with that psychosocial aspect, like patient is anxious, patient is suffering from depression, or even the social factors. Because of the pain, there is a work stress, altered family dynamics. All these things leads to chronic pain. And this is the vicious cycle. So breaking this cycle requires a multidisciplinary approach. So only analgesics or only kind of intervention is not going to help this patient who is suffering from chronic pain. So this chronic widespread pain, the subgroup can be on fibromyalgia syndrome, when the patient is suffering from widespread pain, multiple tender points. Another aspect will be chronic fatigue syndromes. This is also called as myalgic encephalomyelitis, when the patient is mostly suffering from severe fatigue and post-exertional malaise. And both the conditions can have some kind of overlapping. So this coming back to the same patient, so clinical examinations, general appearance like patient looks very tired, musculoskeletal, we can see multiple tender points starting, which is present above waist and below waist. Neurologically it is normal, vitals is normal, systemic with no other issues. Lab findings is mostly normal, just to rule out associated any hypothyroidism or low vitamin D. Inflammatory markers are negative. This fibromyalgia diagnosis is discussed on the previous speaker, the 2016 guide. The most classical feature is the post-exertional malaise. So suppose after working for 6 to 8 hours, patient will complain of profound exhaustions, some mild flu-like symptoms, low-grade fever, and increased pain following minor exertions. So this patient, so why we discussed, the diagnosis is chronic widespread pain syndrome, probably fibromyalgia. The contributing factors like central sensitizations, this chronic fatigue overlap, and the psychological comorbidities. Diagnostic criteria of 2016 guideline of fibromyalgia is met, like tender points count is 8, widespread wait for more than 3 months. So if we come to the see what is the mechanism, why is he suffering from this? One is the central sensitization. I'll come to the next slide. Neurological problems like dysfunctional descending pain inhibitory system. The physical factor like work-related stress, ergonomical issues. Some kind of patient is suffering from also anxiety, depressions, and some social issues like emotional distress, interpersonal conflicts. So the pain sensitization mechanism, there are two types, primary sensitization and secondary sensitization. In primary sensitization, it is when at the site of tissue damage, there is acute inflammation, release of neurotransmitters that is actually helping the tissue to heal. It's applicable for the acute pain. This is good for us. But when this primary sensitization keeps on going, despite the tissue healing, there is a central sensitization that occurs at the level of central nervous system, at the level of dorsal column. So there is a release of excitatory neurotransmitter, glutamate, at the presynaptic end, which gets attached to the NMDA AMPA receptor at the postsynaptic end, and there is a calcium influx. You have to explain the patients what is the reason for the chronic pain, why he is suffering from that, and you have to just make him believe that there is no tissue damage, and you have to set the realistic goals. So you have to tell that you cannot totally improve functional quality of life. Exercise plan is important, like you have to start low dose exercises and gradually go slow. And usually start with the cardiovascular exercises. So increase the strengthening, increase the stretching. Usually most of our activities while you're doing in your daily life, that leads to forward flexion of our body. So extensor group of muscles are not worked properly. So those muscles gradually get, you need stretching of the extensor group of muscle before starting the strengthening exercises. Usually the normal recommendation is like 150 minutes per week. Now next is the posture and the movement. So stretching program along that posture correction exercises to be emphasized, mostly at the workplace ergonomics training, and pain prevention. If there is acute pain, can use the TENS applications when there is if this is available. Occupational therapy's role is like activity management, like you have to pacing the activities. Like first do the heavy lifting followed by rest, take some rest. If there is a possibility of energy conservation, like if the possibility to use the lift instead of stairs, do that. Mainly patient with chronic fatigue syndrome. Sleep hygiene is also important, you have to focus on that, and environmental adaptations. Assistive devices is a good thing for the chronic fatigue syndrome patients. Psychological intervention is required, mostly cognitive behavior to cope up with the pain, and supportive elements, it's already been discussed. So pharmacological management depends on the predominant symptoms. If there is a lack of sleep, start with low dose amitriptyline. The patient is mostly comes with the depression or fatigue, maybe the duloxetine, inside at the PRN basis. So this is the pathway. You can see the secondary sensitization that occurs at the level of the spinal cord, in the central nervous system. So here the neurotransmitter is mostly GABA, which is acting on the NMDA. So here the analgesic, that's why in the chronic pain, analgesic is not going to work. You have to go for the SNRI or SSRIs. If you see the recommendation, the evidence strongly recommendation is like for the patient education and exercise. Rest of the things, all the medication, there is a weak evidence for chronic pain. Lifestyle and adapting therapy is also important. Starting from the nutrition, we all know. A lot of patients sometimes come back. The patients with the chronic pain, maybe they can be better for 5 to 6 months. Later, they can come back with severe pain. Mostly to find out what are the aggravating factors. Classically is low-grade fever or some kind of viral infection, and then again the precipitation of symptoms. So we have to address that, and probably patient education is also important. I'll just touch upon quickly on chronic fatigue syndrome. So it's little bit different than fibromyalgia. Here, standard exercise recommendation can be harmful. It's mainly the graded exercise. Here you have to know the threshold of exercise, at what point of time you develop post-exertional malaise. That can be based on the heart rate. So you have to teach the patients that Suppose patient should do like, I could have done more rather than I did too much exercise today. And at the same time, sleep management and pain management is same like fibromyalgia. But a lot of patients with CFS, they present with complaint of orthostatic symptoms, like while getting up they feel giddy. So that can be treated with a little bit of salt and fluid intake. Use compressive stockings. Just before getting up from the bed, just dangle your legs and then get up. Some medications, if these are not working, then you can go for midodrine or fluorocortisone. Thank you. Any questions? Yes, sir.
But I have one question to ask you. Often we refer to physiatrists the Parkinson's patients with severe dementia. They have already developed dementia maybe. Then what exactly you do personally to for the rehabilitation for them? What are the ways you deal with those people?
Classically, that's for dementia. First thing is like,
Have both the mobility problem and also gradually do they develop obviously depression and dementia, brain fogging. So often they have a non-verbal cues from which we can pick them up. What do you do personally to them?
so mainly the setting, a goal setting is important. Discuss with the family members. What are the aspects patients is suffering from? So maybe activity scheduling is one important task. So because of the dementia, based on what level, if it is MCI, then fine. If it is advanced, then you have to start from the day-to-day schedule. So what are the first things once you get up? What is the next thing he is going to do? Probably they will brush the teeth. They will go to for the loo. So those things to be written in the diary and then address each point you have to follow. So patient is probably not able to remember what is the next thing he is going to do. So we focus mostly on the activity scheduling and teach the family members how to take care of the patients. In case of Parkinson patients, pain that deal with mostly if there is any kind of nociceptive findings, like if the patient is acute pain generator, suppose patient is suffering from knee osteoarthritis or any mechanical low back pain, start with the low grade exercises. And at the same time, some mindfulness therapy and psychotherapy is also important.
Thank you.
Thank you very much, Dr. Sannyasi, for your very nice presentation. Simple question. And in case of fibromyalgic pain, is there any role of mechanotherapy?
So as for evidence, the strongly evidence only for the patient education and graded exercises. Even for the medication also, it is a weak evidence.
Mechanotherapy means message, different type.
Sir, stretching can be an option, but yeah, stretching can be done. But there is no clear guidelines or no evidence for that. It's part of the graded exercises.
Okay, thank you.
I think we can conclude this session. Okay. Any other question from the audience? If there is no question from the audience, we can conclude the session.
Thank you.
I don't see anybody raising their hand. So thank you again, both the speakers and my co-chairs and everybody in the audience. We are concluding the session right now.